Alrighty. First of all, I owe everybody an apology. Sorry for being very late, 10 minutes late. Appreciate your flexibility. Very excited to for another session today. We have a special guest from outside the CP Solvers Academy who's presenting a case. But first, let me thank all the people who are making this happen. First, with Johan, who's scribing. Johan, let me hand the mic to you to say hello.
Hi everyone, I'm Johan, proud member of this family, and really happy to scribe today.
Johan, you're in a different background. Where are you at?
Oh, I'm still in Barcelona.
Amazing. Awesome. I hope you're having a great time today and having a good day. Julia, what are you up to?
Oh, well, I'm so relieved you're doing okay because you're never late. So I kind of was scared that anything happened. So it's incredible how you be on time like each and every day. So thank you for that.
Of course.
I'm actually so excited at the moment because of the residency matching period that's going on, not only because I'm applying as well, but also for all the other people who will get to know where they start their residency tomorrow. So
Mhm.
I'm excited for all the folks.
You're such a kind soul. Thank you for saying that, and thank you for worrying about me. But all is well. I appreciate it very much, and excited to hear your teaching at the end. And I think you'll have a lot of work to do because Sawsan is sharing the spotlight with me. And I have to tell you, I have so much respect and admiration for Sawsan because she, like me, and I identify a lot this in my junior medical years, is kind of a very quiet, soft-spoken leader behind the scenes, but is unbelievably effective. So Selson has been a team member for, oh my gosh, I actually can't really. Selson's been a part of was part of VMR for so long before she became a team member, which is my bad. Um, but I've gotten to know her for well over a year, and I have to tell you, you might notice that she will be gentle and speak softly and slowly and carefully, but behind the scenes, she gets stuff done and is an absolutely brilliant mind. So part of my goal today is to unlock that and have you all see what I know for a fact behind the scenes. So I will hand you the mic, Salsan, to say hello, and then I get to introduce our case presenter.
Hi everyone. Thank you so much, Dr. Ravi, for your kind words, and I'm very happy to be part of the CP Solvers family. I have grown a lot just being part of this team, and looking forward for the session and for contributing more to this family as well.
Oh, that's very, very kind. And congratulations on successfully navigating the mass journey. It's not easy at all, and wishing you the best tomorrow. We have a guest presenter today, who I know a little bit about based on some email exchanges that Gregory does not know that I know potentially. But we're very, very excited. We know that you've been part of the VMR community at large for a long, long time, and thrilled to welcome you here in person. Why don't you tell us a little bit about yourself?
Yeah, well, thank you so much for having me on the podcast. I'm a long-term fan and listener. My name is Greg Kirshen. I'm a first-year maternal fetal medicine fellow at the Hospital University of Pennsylvania. And I don't know if you've ever had an OB/GYN on the podcast before, but I'm very happy to be here and I'll do my best.
Greg, my best friend in medical school went to OB/GYN, and so I continue to get insights into that realm very, very, very peripherally. Yes, this is the first time that at least I'm aware of that we've OB/GYN on CP Solvers, and I couldn't be more excited.
Awesome.
How did you find yourself going to maternal fetal medicine? What was your pathway to that space?
Yeah, so I am sort of internal medicine minded.
Mhm.
I feel like I love the surgery, I love the intensity and the acuity of OB,
Yeah.
but I also love the medicine of it. So I
Mm.
feel like if you want to delve heavily into the high-risk maternal conditions, fetal anomalies, high-risk fetal conditions, maternal fetal medicine is a really good subspecialty to do that. And we get to talk to smart people like you guys all the time, our internal medicine and subspecialty colleagues.
That is amazing. It is really a bridge between worlds that may not seem to overlap, but certainly overlap in your field. That's super cool. How did you know? I don't know of many OB people, OBGYN people who consume CP solvers. How did you come to know this space?
I have a lot of friends in internal
I
medicine,
see.
and I feel like mo if you look at my podcast list on my
Yeah.
phone, it's like all internal medicine podcasts. I feel like
That's
that's how I
awesome.
learned the medicine that I use to, inform my practice. So Yeah, and I feel like I've learned so many teaching points from this podcast.
That's awesome. I'm so, so glad to hear that. What do you like to do for fun?
For fun, I'm a runner,
Mhm.
and I really like to travel with my wife, May.
Oh my gosh, amazing. We have like identical interest. I'm actually dressed to go on a run right after. So I hope you
Awesome.
get a nice run in today too.
Got to run in this morning,
Oh,
actually.
amazing. All right, you're way more efficient and effective than than I am. That's
The
awesome.
weather here is beautiful. It's like 60s in Philly.
Oh my gosh, enjoy. Yeah, it's a little bit colder here now, but it'll warm up to 60s later in the day. So
Mhm.
hopefully I get to enjoy it too. Alrighty, shall
Yeah,
we rock and roll? I think when Johan is ready to share the screen, we will jump right into your case, Greg.
awesome. All right, are you ready if I get started?
Yeah, let's rock and roll.
All right. So first, I'd just like to thank Doctors Kirtan Patolia and Ria Madan for helping prepare this case. And also a quick shout out to my co-fellows who've been intimately involved in this case and have helped to advance this patient's care. So for aliquot 1, this is the chief concern and HPI. We have a 29-year-old lady at 20 weeks gestation presenting to the hospital with 5 days of fevers, chills, and body aches. She woke up 5 days prior to presentation in the middle of the night with full body aches, chills, night sweats, took her temperature, which was 102 Fahrenheit. She took Tylenol, went back to sleep. The next day, she noticed pain in her ribs and hips bilaterally, right greater than left. And in her right lower extremity, she felt a stabbing pain from her hip to her knee. She had been taking Tylenol around the clock, but had persistent chills, dizziness, and malaise, as well as headaches, nausea, decreased appetite, and decreased PO hydration. She denied any vomiting, diarrhea, runny nose, cough, sore throat, shortness of breath, abdominal pain, chest pain, upper extremity pain, dysuria, foul-smelling urine, abnormal vaginal discharge, contractions, leakage of fluid, or vaginal bleeding. And I'll stop it there.
Awesome. Oh, off to quite an explosive start. Johan, just so you know, I'm not sure if you're scribing in a different whiteboard, but I don't think we're able to see what you're scribing, but we can work around that. Um, yeah, Sawsan, what are you thinking?
Okay, so this is an interesting case, especially the patient is pregnant.
Yeah.
So just like seeing the constellation of symptoms, it looks like this patient is inflamed. We can take the IMAID mnemonic and start working through that with the fever, chills. Like it's a systemic process, I would say. It could either be infectious, malignant, medication-related, endocrine-related etiologies. So I'd keep that in mind. But with the fever, body aches, and the acute presentation, I'm prioritizing more like of an infectious process at first. And yeah, her presentation is quite concerning because she's pregnant, especially now she has decreased oral intake, so she requires like immediate attention and admission. Those are my thoughts for now.
Yeah, I love it. I thought like you latched on to the fact that she's inflamed and shared an awesome differential diagnosis for the possibilities of inflammation. Now that you know that she's acutely inflamed, which of those categories are you most focused on?
Um, Infectious.
Yeah, beautiful, beautiful. And so now the practical exercise in this patient becomes how do you approach infection in her? So I'm really curious just what your reflex thoughts are about acute infection, and then maybe after you share that, how your thinking is a little bit influenced by the fact that we don't have just one but two patients before us. Yeah, how does that influence your thinking?
Um, So for the infectious, I would start with the common infections,
Yeah.
common things, viral being like the most common,
Mhm.
especially the systemic and the hyperacute presentation, and then going like to also common bacterial infections. But I'm prioritizing maybe viral and maybe like depending on the location of the patient, like tick-borne infections could
Beautiful.
present this way.
Yeah, I think that you're absolutely right that, viral and common bacterial infections are the things that we think about, but we have to pay attention to the patient's environment. And the reason we think viral is they're the most common kind of universal environmental organism. But if a patient has unique environmental exposures, we certainly have to entertain those possibilities as well. And so that's the blueprint for infection in all comers, but we pay attention to specific features of the story and specific host risk factors. So I'm just curious, from big picture, how does her being pregnant influence your analysis of infections? What does that do for you?
Mm. So for her being pregnant, okay, how does this influence my thinking?
You may
So, yeah, go ahead, Doctor.
Oh yeah, you may not have dealt in this space, certainly not very frequently, knowing that you're matching in internal medicine. I just have to help our team with the whiteboard. One sec. Let me just do that real quick. Okay. All right. Yeah, it may not be something that you have thought about, but let me give you a framework to answer that. So whenever you're really trying to figure out, does the host influence things, you're wondering, is the host systemically immunodeficient for any reason? Or is the host structurally immunodeficient? So as an example, if I told you that the patient has COPD and structural lung disease, you might think, oh, maybe they have a infection there. Or if I told you that the patient has HIV, that certainly changes your calculus. So do you think of pregnancy as either a systemic immunological issue or a local immunological issue in any way?
Um, I think more like a systemic, because like they have low immunity during pregnancy.
Exactly right.
Okay. Normal state.
Exactly right. Yeah, in order to be able to essentially tolerate a half a foreign antigen, your immunological system has to adapt to that. And so it is really interesting, the immunological system in pregnancy. I think unlike HIV, where there's sort of a blanket immunodeficiency, we by studying autoimmune diseases, we learn that some patients with pregnancy, their autoimmune diseases get better, and in some they get worse. So there's an immune dysregulation. But I think in the terms of infection, I think we entertain the idea that patients who are pregnant have some kind of immunodeficiency, but it's actually a very interesting, complicated immunodeficiency. That's not a all blanket one. So, for example, you're not at an incredibly high rate of having cellulitis, for example, but you have a subset of unique organisms that affect pregnant patients disproportionately. And I'll just throw out some ones to make this concept attach, which you certainly have heard of in your step studying. So you probably have heard of how hepatitis E is so much more fulminant in pregnant patients. You've heard about listeria and how it's so much more serious in pregnant patients. So you'll hear about these bugs. And the general theme that you might notice about these bugs, Sawsan, is most of them are intracellular organisms. Most of them. So the two examples I just gave you are also intracellular organisms. But in parallel, the fact that there's a now gravid uterus. The question is, does that predispose a structural place where patients who are pregnant are more likely to have an infection? And the answer is yes. Patients can get all sorts of local infections in that region, in the uterus and the draining pelvic veins. And so, unfortunately, in the world of pregnancy and infection, both those categories, the systemic immunological dysfunction and a structural propensity to host infections in a certain location, namely the gravid uterus and the draining veins. So we really, really have to be very, very vigilant in this patient for some special bugs and to make sure that we add another location of infection to our list of possibilities, which is a really hard job to do, quite honestly. Um, and finally, I'm really curious what you're making of her specific symptoms. So she's having these chills, night sweats, stabbing pains in her chest, hips, and ribs. Did that do anything for you?
Yeah, like these symptoms are like non-localizing, they're non-specific.
Yeah.
They're just telling me like the whole body is inflamed or like systematically involved for now. And it makes me more think of a viral. I don't want to anchor from now, but just
Yeah.
like, yeah, those
Yeah,
are
I completely agree with you. I completely agree with that analysis. She has symptoms everywhere. I will tell you that I latched onto that as well, but I was really intrigued. I've never really taken care of many patients who have stabbing, rib, hip, and leg pain. And because that's unfamiliar, my mind is naturally like, you know what? That's probably just as you said, non-specific cytokine discomfort NOS. But it's so unusual that I'm wondering, wait, is it a knowledge gap on my end? And am I being lazy in my reasoning by discarding the significance of that concern? So I'm going to be paying attention to on exam. Is she more diffusely achy, or does she really use her fingers to point to those specific areas? And if she does, I wonder if we should revisit our instinct of NOS and say maybe there is a focus there for us to analyze. But we've talked a lot, so maybe we can hand the mic to Greg to tell us a little bit more.
Awesome. This is a brilliant discussion, and I love everything that's been said. And I feel like you guys are already on top of what's going on. So, but I won't give too much away other than giving you the next aliquot. All right. So her past medical history is notable for sickle cell beta thalassemia. She did have a recent admission earlier in the month for a vaso-occlusive crisis with bilateral lower extremity pain. Workup at that time was negative for avascular necrosis or venous thromboembolism. She received 1 unit of packed red blood cell transfusion, was managed with patient-controlled analgesia, and was discharged home with as-needed oral oxycodone. Her current pain regimen and her medications include Tylenol around the clock for pain crises, as well as oxycodone, 10 milligrams every 6 hours as needed, and heat packs. No other medications, no allergies. In terms of her past social history, she is a non-smoker, no alcohol use, no drug use, no recent travel outside the country. She works as a phlebotomist. And for her family history was non-contributory. Her obstetric history, she had 2 prior full-term C-sections that were uncomplicated and no pertinent gynecological history. And her review of systems was otherwise negative. In terms of her physical exam, her vital signs, her temperature was 101.8 Fahrenheit on presentation to the ED. Her pulse was 104. Blood pressure was 129/56. Her respiratory rate was 16, and she was saturating 98% on room air. Generally, she was well appearing and not in any acute distress. Neurologically, she was alert and oriented, appropriately conversant, with no focal neurological deficits. On lung exam, she had unlabored breathing on room air. She did have some inspiratory wheezes in the left lung field, otherwise no crackles or rails. On her chest exam, she was tender to palpation over the right ribs 9 through 12. On her heart exam, she was regular rate and rhythm. S1, S2 were present. No murmurs, rubs, or gallops were appreciated. On her abdominal exam, she was gravid. Her abdomen was soft, non-tender, non-distended, without rebound or guarding. And on her extremity exam, she had bilateral swelling in the lower extremities that were non-pitting. She did have tenderness in the bilateral lower extremities as well, right greater than left. And pelvic exam was deferred. And her fetal heart rate assessment, the fetal heart rate was 140 beats per minute, which is normal. And I'll stop there.
Greg, I'm so glad you told us what the normal was because I was about to panic. I was about to panic there. I think temporarily, Sawsan, we can focus on one patient right now and not have to worry about the fetus.
Right.
Hopefully, leave it on Greg to help us with that. But yeah, what happened in your calculus there?
So looking at her past medical history and her having sickle cell is like a risk factor for like vascular necrosis and bone infarcts, and also like it's a risk factor, like her being sick and, for example, having an infection can trigger, for example, a vaso-occlusive crisis, and so can like this leads to worsening of her symptoms as well. And it's good that her 2 previous pregnancies went well. So this tells us like this is less likely to be a OBGYN related issue, and it's more of a systemic problem. And given her vitals, she's stable. But what I'm thinking about her ribs at like the right side of her body, and they're tender to palpation. Are they like the ribs themselves, or like should I be thinking about the liver as well? Just because like it's in the same area. And And about with the bilateral swelling in her lower extremities, I know that she's 20 weeks pregnant. I'm not sure if if it's normal to see them from now, or like do we see them later on? But
I'll tell you that her lower extremity swelling was out of proportion to what we usually see in pregnancy.
okay, that's good. So okay, that's interesting. I'm wondering if there could be something compressing, causing that kind of swelling, and her being pregnant and history of the sickle cell, and she's kind of dehydrated. This also, like, I don't want to exclude a thrombus or a thrombosis happening as well. I don't know, honestly. I'm just babbling a lot.
No, not at all. I mean, I think quite honestly, I think that, you mentioned as as you were doing your second discussion about trying to get your thoughts out there being one of your goals and being able to flow. And I think you're flowing effortlessly. I admire how much you acknowledged how profoundly the sickle cell history changes the calculus today, and I have nothing to add to that, but to also emphasize that treatment for sickle cell disease influences our calculus. Part of the environmental exposure list of infections we have to entertain are blood-borne infections in patients who receive transfusions. So on your checklist is now not just sickle cell and its complications, but the complications of transfusion. And so, I've had too many sneaky cases of transfusion-borne diseases not to keep that in our back pocket. So that's the only thing that I will sprinkle on, in addition to your excellent thoughts about how sickle cell camouflages this presentation, and it makes it harder to figure out what's sickle cell and what's not sickle cell. And I think, like you, I'm very worried about this patient's exam, not just because of how febrile she is, but also because I think there does appear to be very concrete signal in two discrete locations which you identified. There seems to be an osteoarticular bony element to this disease process, but also a vascular leak component. And I think the truth is that her bony analysis will be made a lot by seeing if she's hemolyzing more, in which case I think the default diagnosis would be sickle cell crisis. But of course, infections that go to the bones would also be something we worry about. Um, uh, but I think the other focus is, as you pointed out, to be 20 weeks pregnant and have this much edema. And I really appreciate Greg emphasizing that now we have another problem. So I'm really curious now if we just take a minute or two to remove ourselves from this patient and use this opportunity to practice how you think about bilateral lower extremity edema in general. So what would be your sort of kind of master schema? Then we'll apply it to this patient.
So for bilateral, we would think of something systemic that's happening. It's either involving the heart, sorry, or the kidneys or the liver. This is like my initial framework for.
Outstanding. Yeah, I think that a very simplistic journey is one that emphasizes the heart, liver, and kidneys, and then realizes, as you said, that those three considerations are all often laboratory positive. A high BNP, dysregulated liver enzymes, kidney dysfunction / albumin can really help you make tremendous progress towards the cause of bilateral lower extremity swelling. If we were to pretend, Sawsan, and we're trying to make a master schema here, that you send off a BNP, liver enzymes, kidney function, and albumin, and they're all normal in a patient with bilateral lower extremity swelling, what do you think you've now left on the table?
I would think of either I think I forgot also to mention thyroid could present with bilateral, or something anatomical that's going well.
Beautiful. Beautiful. So, when I take care of patients with bilateral lower extremity edema, it's effortless. You send off the labs, you become pretty good at like having a pretest probability. You send off the labs, and the labs usually reinforce your pretest probability. So I see somebody who's jaundiced and confused and has lower extremity edema, and there go the LFTs. I see somebody who's super hypertensive and has lower extremity edema, well, there's creatinine. I see somebody who has tachypnea, distended JVP, and has lower extremity, where there's their BNP. And in this patient, it's interesting. She's not hypertensive, so kidney diseases are a little bit less likely. She's not jaundiced, so liver diseases are a little bit less likely, though possible. And she does not have tachypnea, So cardiac diseases are a little bit less likely. A little bit. The labs will help us reframe our analysis, but I'm already thinking, okay, what if those three things are negative? What do I have to worry about? And venous stasis is by far and away the most common cause of laboratory negative bilateral peripheral edema. But as you will see in a rapid fire VMR later, thinking about the IVC is really, really important. So for me, I'm prepared to see if the labs push us towards a concrete organ that you already mentioned. But if the laboratory data is negative, we really have to worry, is the IVC involved here? And it's important, more important to worry about IVC involvement in a patient with any hematological or hypercoagulable disease, such as sickle cell. So that's in our back pocket. A lot of work to do. Maybe we can hand the mic to Greg to tell us what you have next for us.
Awesome discussion. I love it. And I love how you guys are kind of tracking different things as more information's coming out. And really, you guys are doing stupendously. All right, so aliquot 3 are going to be initial labs and imaging. So her white blood cell count was 2.7 with 9.7% bands. Her hemoglobin was 7.1. Her platelets were 106. Her reticulocyte count was 0.8%, and her absolute count was 27. On her chemistry, her sodium was 135, potassium 3.1, chloride 104, bicarb 22. Her creatinine was 0.64, calcium was 7.5, albumin 2.7. Her total bili was 0.9, direct bili of 0.6. Her AST was 43, ALT 11. Her haptoglobin was 102, with our normal reference range being 36 to 195. Her LDH was 632, with our reference range of 98 to 192. Her ferritin was 1,244, with our reference range being 11 to 300. And her proBNP was 991. She had a negative respiratory viral pathogen panel, and she had 2 sets of blood cultures, which were negative, and a urinalysis, which was normal. She underwent a CT of the chest, abdomen, and pelvis, which showed no acute pulmonary embolism, mild wall thickening of the peripheral bronchi, probable bronchitis, gravid uterus, hepatosplenomegaly, no drainable collection in the abdomen or pelvis. She had bilateral duplex ultrasounds of the lower extremities, which were negative for any DVT. And she also underwent a fetal middle cerebral artery Doppler, which demonstrated severe fetal anemia. And I'll stop there.
Oh my gosh, wow. All right, Sawsan, what are you thinking?
Okay, these are some interesting and concerning labs, honestly. So starting with her CBC, she has, I would say, pancytopenia. Her retics compared to usually in sickle cell, and if the patient is hemolyzing, would like to see, we would usually see higher retics, but in her case, we're not. So I'm keeping that in mind. And for her labs, also she has elevated LDH, low haptoglobin. So there could be some degree of hemolysis that's happening, I would say. Her ferritin is elevated. Her albumin being 2.7, this could be as because it's a negative acute phase reactant, so I'm just gonna put it aside for now. And even her proBNP is elevated. Trying to connect the dots. So for her respiratory panel, what does it usually include, in your hospital, if I can know?
So our respiratory panel will include flu A and B, COVID-19, and then a lot of the more common, I think of less grave viruses, like other coronaviruses and adenovirus and things like that.
Thank you. And especially now with the fetal Doppler showing some anemia, so this is getting to the baby. Could this be like a parvovirus infection affecting her even because like due to her British count and the baby is having anemia, or another autoimmune process that's happening alongside, like an infection that's triggering a type of autoimmune anemia, like maybe IgG related, something that can cross the placenta and attack the RBCs of the baby. Honestly, I don't know how to really connect the dots for now, but I'm gonna still look for more infectious causes.
Yeah, Sultan, I think that, it's whenever you do a lot of work, including pan scanning a patient, and you still don't have a clear pivot point, it becomes tricky to try to say, okay, uh, here's how I make progress. In other words, I think your mind was probably realistically expecting to be able to make tremendous progress when you look inside this patient and from a laboratory and radiographic perspective. And the lack of it can be very discombobulating. You're like, okay, where do I invest my energy? But I think you can really make a lot of progress by realizing what you've eliminated. So you've eliminated cellulitis, you've eliminated pyelonephritis, you've eliminated a liver abscess, you've eliminated a severe pneumonia, you've eliminated COVID, flu, you've eliminated many things. So the question really is, where is this inflammation coming from? And I think by far and away, the most common cause of inflammation that is not radiographically evident is because it's in the blood. And detecting blood-based diseases radiographically is almost impossible. And by blood, I both mean that there is a purely hematological issue or a pure infection in the blood, but also the very well described phenomenon of a focal area of inflammation, like the upper respiratory tract, causing cytokine storm in the blood. And so for me, I think that when you say that somebody has a hectic image negative syndrome, I simply ask the question, well, what is it that I cannot see? And I think this is why we have laboratory radiology. And I think the lab is very, very good at telling us blood-based problems. So I'm like now thinking, okay, my answer is probably going to be analyzing the blood better. And I think the first step is to say, well, let's analyze the CBC as best as we can. And I might have missed it. Like, Greg, maybe you can clarify. Well, did she have appropriate reticulocytosis, or was it
Yeah, her reticulocyte count was normal, and not suggestive of like a sickle cell flare.
gotcha. Okay. Yeah, so I think that that's very helpful, Greg. Thank you. Yeah, so I think she has an anemia, she has a leukopenia with bands, and she has a high LDH and a low procal. I think that it's really, as you said, it's really hard to try to say, okay, it's really hard to say, like, what do you do to make progress now? Is she hemolyzing or not? And on balance, I'm not sure if she has acute on chronic hemolysis. Her haptoglobin is normal. Her LDH isn't through the roof. Her reticulocyte count is not compensating higher than it is. So I'm having a difficult time saying if she's hemolyzing, but I don't think so on balance. I'm curious, Greg, if you happen to know what her platelets and white count have done compared to her last hospital stay.
Her platelets and white count were lower than they had previously been.
Gotcha. So to summarize, we essentially have a relative leukopenia and thrombocytopenia with a relatively stable hemoglobin. Is that a fair comparison of her CBCs, or has her hemoglobin also dropped?
Hemoglobin dropped a little bit. I think her baseline was around 8.
Okay, gotcha. Okay. Yeah, so see, I think it's very, very difficult, as you suspected, to disentangle the sickle cell from what's going on now. But I think essentially we have a situation where we have pretty impressive white count drop, pretty impressive platelet drop, and a relatively stable hemoglobin drop. So I'm curious, what does that do for you when you see that pattern? What does that make you think of?
I'm thinking now of like tick-borne infections. And I think I got it wrong. I thought that the haptoglobin was low, so the patient has no hemolysis for now, or like no indications of hemolysis. It's just like the leukopenia and thrombocytopenia. Maybe like thinking of, okay, I forgot the name of the infections. Um, dengue, I think, can present like this. I forgot, honestly. Where is Yaz to
Oh yeah,
help?
no, don't worry. Oh my gosh, yeah, Yaz is always around. Don't worry. But you know, when you come to the US and this becomes a daily experience for you, you'll be more inclined to think of them. But I think, yeah, I think that we have so much evidence that this is a blood-based disease by the fact that she's so inflamed, and yet we don't know where it is. And how you analyze blood-based diseases is really through studying the CBC as well as you can. So I think for now, we really have to focus on blood-borne infections. And I think as we talked about in the academy, I'm not sure if you were there or not, you can have macroscopic infections in the blood. And those infections are infections that you can grow on culture.
Mhm.
Importantly, it's also important to recognize that you can have microscopic infections in the blood. And microscopic infections are infections that only can be either PCR'd or seen on peripheral smear. And I think it's helpful to organize your microscopic infections by where the infection hides inside the hematological system. So if you have a microscopic infection of red blood cells that typically causes a hemolytic anemia, the worldwide example of that would be malaria, and the US example of that would be Babesia. You can also have microscopic infections of the blood that hide in neutrophils or monocytes. So human granulocytic anaplasmosis, HGA, is a classic example of a exogenous organism that hides in neutrophils. Rickettsial organisms are very, very similar. You also can have monocyte-based infections. These include human monocytic ehrlichiosis and Bartonella. So the sort of like short overview of these microscopic infections are: where are they hiding? In neutrophils, think human granulocytic anaplasmosis, rickettsial infections, and typhus. And then monocytic-based infections would classically include human monocytic ehrlichiosis, but also Bartonellosis or Bartonella quintana is a classic example. Long story short, you don't need to know all this. Whenever you have somebody who has fever that you cannot localize in a specific organ, you have to think blood-based infection, send off blood cultures, but also study the patient's epidemiological exposure for the possibility of microscopic infections in the blood. And the progress that we can make with microscopic infections is by studying the peripheral smear to see if we see those organisms, but also PCR-based testing. The hardest decision is to decide whether or not to empirically treat patients for these infections while you're awaiting the results, especially in a patient who's pregnant. Because as far as I know, doxycycline would be the choice, the antibiotic choice in patients that I take care of. But I'm really curious how Greg was approaching this in this patient. But I think that's where I'm at, right there with you. And for the sake of time, why don't we hear from Greg and then see what else, what other progress we can make.
Yeah, this is great. You guys are definitely, on the right track, and I love the discussion. So I'm about to throw a lot of information at you. So this patient got worse. So she continued to spike twice daily fevers as high as 105 Fahrenheit, and required a dilaudid PCA for pain control. She was started empirically on vancomycin, cefepime, and azithromycin. We don't use doxy in pregnancy, or azithro is sort of our counterpart. She was counseled about the severe fetal anemia and her options for either intrauterine transfusion via PUBS procedure versus termination of pregnancy versus expectant management. And she ultimately opted to undergo a dilation and evacuation procedure. After the procedure, her daily fevers persisted and became temporally associated with brief episodes of altered mental status lasting about 10 to 15 minutes. She developed vitreal hemorrhages, and hematology, infectious diseases, neurology, ophthalmology, and rheumatology were all consulted. She underwent additional workup, which demonstrated, and I'll categorize these by organ system or type, just because there's a lot of them. She underwent infectious studies. She had negative EBV, negative CMV, negative HIV. She was positive for parvovirus IgG, negative IgM, but her parvovirus PCR was 364. Her peripheral smear was normal ×2. She had a negative tick-borne pathogen workup, including negative Babesia, negative Ehrlichia, negative Anaplasma. She also had negative Toxoplasma IgM, and she had a Carius test, which basically tests for all microbes that can be detected by PCR, which was negative. She then underwent like immune activation / inflammatory studies. She had a CXCL9 that was 12,900, which is elevated. She had a cytokine panel, which showed an elevated interferon gamma of 239, elevated IL-6 of 18, elevated IL-8 of 48, and elevated IL-10 of 3, elevated TNF-alpha of 10, and her ESR was 47, CRP was 16.6. In terms of rheumatological studies, she had an ANA, which was 1 to 80, with a negative anti-double-strand DNA, normal anti-Smith antibody, normal anti-SM/RNP antibody. C3 and C4 levels were normal. She had an angiotensin converting enzyme level, which was 93, the upper limit of normal being 85. And then in terms of labs that I'd already told you about, just trending them, her white blood cell count remained low at 3.9. Her hemoglobin downtrended to 6, and her platelets downtrended to 23. Her haptoglobin was 78, and her LDH was 487. A repeat ferritin was 3,065. And then her reticulocyte count was 2.8% with an 80.6 absolute reticulocyte count. She also had a dilated eye exam with ophthalmology, which showed retinal phlebitis. And she underwent a head CT given the periods of altered mental status. The initial head CT showed no acute findings. And I'll stop there.
Oh my gosh, Greg. Wow. Turn on the heat there. Okay. Sawsan, where are you headed with this case?
Honestly,
Yeah.
wow, I didn't expect all of this.
Me either.
Yeah.
It's very unfortunate for the patient that she had to terminate her pregnancy, but there's some things that I'm not really familiar with. For example, the CXCL9. I don't know what does this stand for, but it's concerning, I would say. Okay, maybe I have to be more systematic with, but like most of the infectious things that we were thinking of were negative, so we exclude them. And with all the cytokine, like, is this like a kind of a cytokine storm that's happening? I think I need your help, Dr. Rabih.
No, I think you're absolutely outstanding. I think that's exactly, you know that the patient's now horrifically inflamed and persistently so. And I think that it's interesting to study two things: the fact that you haven't found an infectious organism, and that the case has not evolved in a way that results in sort of hemodynamic significant shock. And so I think both the fact that you haven't found a concrete bug, with the exception, of course, of the positive parvovirus PCR, which we can talk about in a moment, you're seeing, I think, a relatively high chaotic inflammatory response in a patient who you have not found a fulminant infection for. So I'm just making note of that disconnect of what we would expect if the inflammation and the consequences were of equal proportion, where a patient would now be very, very hemodynamically sick at this point, or has significant end organ consequences. And her end organ consequences seem to be very prominently hematologic, out of proportion to anything else. And so I think zeroing in on that and saying, okay, well, what is this hectic hematological syndrome. And I think the hematological syndrome is characterized by pancytopenia. And so you ask yourself, okay, well, what can cause a hectic inflammatory pancytopenia? And the differential diagnosis for hectic inflammatory pancytopenia is very, very limited. And the first is really tick-borne diseases. The second is lupus, and I think both those are relatively unlikely in this patient because of how much work we've done to eliminate tick-borne diseases and the fact that her DNA, all her subserologies are negative. So I think the exercise that you and I can go through is, what are the less common causes of a hectic inflammatory syndrome characterized by pancytopenia? What do you think?
Mm. I feel so sepsis can
Yeah.
do that.
Definitely.
What else? Maybe what else?
Yeah, let me show you.
Yeah, heme cancers.
So you already saw that. We have to worry, does he have a hematological issue for sure? I think we're starting to really worry, does he have HLA? And I think that's this, like you ask yourself, like, what really causes a fever and pancytopenia? I think practically speaking, as you said, you have sepsis, or you have a hematological cancer like acute leukemia and the patient's infected. Those are the practical considerations. And I think when you say, you know what, she's been this sick for so many days, yet she's not in any hemodynamic physiology. I haven't been able to find a bug. She doesn't have any underlying hematological cancer. You start to have the operating framework of HLH. And I think when you see how high her ferritin is, when you see how a CXCL9 is another marker of macrophage activation, and so you're really saying she has macrophages that are going crazy by secreting this amount of ferritin and this amount of CXCL9. So I think the working hypothesis of HLH starts to loom large. But as we've discussed many times before, Sawsan, HLH is really just your body reacting to something. Admittedly, a very small fraction of patients with HLH, there's nothing the body's reacting to, and it's primary HLH. But for most people, including somebody at 29, HLH is reacting to something. The first question that we have to ask when we're starting to suspect HLH is, no matter what is triggering the reaction, is the reaction so life-threatening that we have to shut it down? So we acknowledge that HLH is a vigorous response to something in most people, but at some point, the response gets so vigorous that we have to shut it down. So the first question we have to ask is, do we need to immunosuppress this patient to save her life? And that's a very difficult conversation with experts usually. And in parallel, we say, well, what triggers it? And so I think I'll just share that we usually ask ourselves what's triggering it by having a very robust grasp of the time course. Because what triggers it can be infections and autoimmune diseases and cancers. But when somebody literally 5 days ago was fine, it's hard not to skip over infections. And if you just search parvovirus HLH, you'll get a lot of hits, unfortunately. So I would just share that I think the response now of the body is so vigorous that we probably should talk with everybody in the room about, should we start to immunosuppress her and treat her for HLH no matter what the cause is. And we've already pan-scanned her, so she doesn't have a solid tumor hiding. And there are not many autoimmune diseases that cause HLH, with some exceptions like Still's disease and lupus. So the question is, does she have a cancer or does she have parvovirus-induced HLH? And I think that the recency of her illness makes an argument against cancer. But I think the operating framework here is now HLH in a patient with sickle cell disease. And I'm curious what other thoughts you have, what questions you have, and how we can make progress.
Uh, I don't think so. I have a question right now. I think you explained it really well. So,
Yeah, yeah, for sure. I think that the next step is probably a consideration of empiric treatment and then a bone marrow, and a bone marrow with the idea being that you don't want to be sitting on an acute hematological malignancy, which we talked about, but also this rare association that I've read about of what sickle cell can do is it can cause bone marrow necrosis. So it's actually more common in patients with sickle cell beta thalassemia than sickle cell to necrose the bone marrow, and that can trigger an inflammatory reaction like HLH. So I think a bone marrow might be helpful for leukemia and for necrosis, sickle cell necrosis. But I would be really anxious not to start treating this patient empirically for HLH, even though we don't know the cause.
I just have one question. So now to analyze the
Yeah.
results of like the parvovirus. So now for the IgG, it's not very like important for us right now, but like does the PCR is it what made you think of the HLH could be like induced by it?
Yeah, it's a tricky analysis because technically the IgM is negative, the IgG is positive, so that would suggest that she has had a previous infection, but her PCR is low-grade positive. And so is that noise? Could it be noise? For sure. But could it also be amidst the diagnostic vacuum? Could it be a clue? And I don't know what to make more of it than just to recognize that I don't have enough knowledge to be able to fully dismiss it, or fully lock into it. But maybe Greg does.
Yeah, so we had actually spoken to infectious diseases about how to interpret her parvo serologies and PCR, and they really told us that the antibodies, the IgG and IgM, are not as reliable, and the PCR is really the gold standard. So if you see a positive PCR, then that's going to be most helpful in identifying a positive infection.
There you go, Sassan. We got our answer. That parvo is real. And the question is, does it explain everything? I think the answer is by itself, no. But is it talking to the body in a way that the body doesn't like? Very, very possible. All right, Greg, Mike, to you. What you got?
Awesome. This is a great discussion. All right, so I'm going to give you the final aliquot, and then I'll have you put your nickel down on diagnosis before I give you the final piece of information. So she did undergo a head MRI given the periods of altered mental status she was having that were associated with her fevers that showed punctate focus of frank-Willen enhancement in the right frontal white matter, as well as non-enhancing T2 hyperintensities with suggestion of mildly decreased diffusion in the left periatrial region and left cerebellum. These were new. And then she had a follow-up MRI of the head 2 days later, which showed a few non-specific focal flare hyperintensities within the left temporal white matter. She was recommended for an LP, but was unable to tolerate one. Given the findings of her infectious workup, antibiotics were stopped, and she received a 2-day course of IVIG. She had a repeat parvo PCR, which was negative. However, given the lack of her clinical improvement with the IVIG, the decision was made to start a course of steroids empirically. So she was started on prednisone 60 milligrams daily. She remained in the hospital and started to feel symptomatically improved. Her follow-up labs revealed a white blood cell count of 6.1, a hemoglobin of 9.1, and platelets of 48. Prior to starting the steroids, she did undergo a bone marrow biopsy, which will reveal the final diagnosis.
Greg, this is absolutely amazing. Greg, do you have something scheduled in the next 10, 15 minutes or?
No, I'm good.
Awesome. This case has been such an amazing journey and we've been flying through it that I would love, nobody's opposed, to give Sawsan some time with her CPS colleagues by doing just a brief 3-minute breakout room to really reflect on the learning in this case and to see what progress we can make. So why don't we just hit pause on the recording. All right, welcome back, everyone. Sawsan will be here in 3, 2, 1. Okay. Hi. So Sawsan, you were some very, very savvy people. What did you learn? What did you come up with?
Yeah, we were talking. So Catherine shared her thoughts about like the possibility of HLH, but like thinking of what is triggering the HLH, and infectious causes are still on her differential. And then we were talking about like the stroke findings and the hyperintensities that were found on the brain MRI. And we walked through with Mengyu about the pump, pipe, and plasma framework for that. And we also talked about like the possibility about like her having sickle cell is also like a risk factor for her like clotting and having these findings. And those were what we talked about in our room.
Yeah, fascinating. Yeah. What is your instinct saying? What do you think might be the unifying hypothesis here?
Um, so I know like to diagnose HLH, we need like the cytopenias, the high ferritin, the hypertriglyceridemia. Like there's, I think that pentat where I forgot
Right.
like how many things that are.
It's a lot of things, yeah.
But like with her liver enzymes being they weren't elevated. And I don't know what other things. I know it's a bit hard for me to really
Yeah.
I really can't tell if yeah, it could be like HLH and presenting in that way, or it's something completely else, but mimicking an HLH process. Honestly, I don't know.
Yeah, I think ultimately we're so glad that the patient is improving on steroids, and all we can say is we hope it's a sustained improvement. And I think the fact that she's starting to head in the right direction gives you an insight that you're doing something right, hopefully not temporarily. And so I think using that as the ultimate clue to say she has a hyperinflammatory syndrome on the spectrum of HLH is really key. And then the question is what triggered it? And I think the triggers, the fact that she's improving with steroids argues against a robustly active infectious process that's doing so. Again, assuming that the response is sustained. And so then you ask yourself, like, what causes HLH in all comers that's not infectious? And then what about this unique patient? And I think if you hear the words sickle cell and punctate strokes, you wonder about sickle cell itself being thrombogenic and causing strokes, but also in a patient with recent sickle cell crisis, the possibility of fat emboli. And so fat embolism syndrome occurs spontaneously in patients with sickle cell disease as a result of fat from the bone marrow that's released into the periphery. So for me, I think that this seems to be related to her sickle cell disease, and whether she has a really bad sickle cell crisis that triggered HLH, or whether she has a unique fingerprint of bone marrow disease that has resulted in fat emboli, and that fat embolism spectrum has triggered an inflammatory response is something I've never heard about, but very, very intrigued by. So if I were to make an educated guess as what did the marrow show, I don't think it's going to show an infection. I don't think it's going to show a cancer, though I would be open to both and humbly learn from them. I worry the most about the possibility that this is a manifestation of sickle cell infarction of the bone marrow with subsequent dislodgement of fat emboli and triggering of HLH. Ultimately, let's keep hoping that she has improvement with immunosuppression and learn as much as we can from Greg.
Awesome. Great discussion. Love it. So I'll give you guys the final diagnosis. So she underwent a bone marrow biopsy, which revealed cellular marrow with megakaryocytic atypia and hemophagocytic histiocytes, suggestive of hemophagocytic lymphohistiocytosis. I'll tell you a little bit about her course. So multiple teams had raised the possibility of HLH secondary to a parvovirus B19 infection. At this point, her working diagnosis is secondary HLH, although during her admission, hematology was a little skeptical. They weren't entirely convinced of the diagnosis, given the milder magnitude of her laboratory derangements compared to more clear-cut cases, and the difficulty in interpreting her pancytopenia in the setting of her baseline anemia from sickle cell. The patient was feeling better and had an improved fever curve, symptoms, and labs with a decreasing ferritin and improving white blood cells and platelets, and was ultimately discharged home on hospital day 32. She did represent 2 days later with fevers up to 103 at home, and in consultation with rheumatology was started on IV methylprednisolone and anakinra, and was ultimately discharged home on hospital day 8 after improvement in her fevers and her inflammatory markers.
Oh my gosh, Greg, we have to learn from you. I'm really curious what your journey was like and what you learned from this case.
Yeah, this was really one of the most fascinating cases of my short career so far. And it was very humbling. It was, I think that one of the major points for me was just getting everyone in the same room. So like talking with rheumatology, heme, ID, MFM at the same time to kind of put our heads together, because I think it's difficult when, you know, each of the teams are like coming and rounding on the patient independently and writing their own notes, but nobody's like necessarily talking together and putting the whole picture together. So that for me was one of the big take home points.
I mean, I couldn't be more grateful for you being, being our first ever MFM fellow in this space and presenting a case that really, I think, straddles our worlds. And I'm very, very sad to see the sheer consequences of HLH and what it can do to somebody in general, a 40-day hospitalization, but also the premature loss of a life. And I think it's so much easier it's so easy to lose sight of just the additional consequences in your world, not to minimize the consequences alone in ours. And yeah, I can't imagine how dizzying this journey might have been to think of all the different pregnancy related possibilities, adult possibilities, and then sickle cell related possibilities, to ultimately realize that this was just the body going crazy and not knowing exactly why. It makes it even more hard to swallow. But the journey and the learning along the way was so rich. So thank you so much for bringing it. I'm curious, Alsan, what were your reflections?
Honestly, this was a very interesting case. And so thank you very much, Greg, for sharing it with us. It's like the journey was quite like kind of like unexpected. Like the story I thought it would be something more like less complex, but the way it ended is quite interesting. I feel like I have it was nice because I know now what like my knowledge gaps are and what to focus on and like what to read on, especially that about like my illness script about HLH and like how to suspect it and diagnose it. But I feel like I need more time like to be able to reflect on it. So, and thank you very much, Dr. Robbie, for walking me through it.
Yeah, if you show up to intern year on the first day being able to diagnose and treat HLH, I think you're doing okay. So I don't know if you need to fine tune your own script for it. I think that it is a leap goal to have, and I think you're ready to achieve goals like that. But I just want to make sure that all of you know that it is far, far, far in excess of what you actually need. But that I think defines what you're doing, Salsan, and I'm really, really cool to see you really shining today. Maybe before we hear from Julia to recap the learning points, I'd hand the mic to you, Greg, to sort of summarize any learning that any sort of like medical aspects that you want to emphasize before we hear from Julia.
Definitely. One thing I will say, and this is also one of the reasons I chose MFM, is this is a lesson I learned intern year from one of my mentors at Hopkins, Dr. Amit Bashat, who was one of the MFMs there, is that the fetus is another vital sign that you can use to assess patient stability and also provide clues to an underlying diagnosis. So the fact that the fetus had severe anemia and the patient had fever and pancytopenia, if you put all those together, parvovirus becomes kind of like rises to the top of your differential.
Yeah, beautiful. That's such a great pearl. Thank you so much for sharing it. I really, really appreciate it.
For
All right,
sure.
Julia, you added one other teaching pearl to your to your list there. Take it away, my friend.
Greg, you got me on the edge of my seat all the way through, and I'm so grateful that you put some input or you provided some like totally different input to this space. So please come back. So I'll try to summarize a little bit what journey we went through, and Sawsan did really a wonderful job. So we started with a 29-year-old female. She was pregnant and presented with an inflammatory syndrome. So she had fever, chills, and body aches. So we started off with our IMA mnemonic to make sense of the fevers and prioritize infections. And then we also learned that it's always very important to keep track who is our host. So our pregnant woman she is in an immunosuppressive state. So we should be aware of any special bugs and also special locations that are associated to pregnancy. Second, we learned that our patient had sickle cell disease. So we also should be aware of any treatments, and in sickle cell disease, patients are vulnerable for transfusion complications. Then in the physical exam, it was notable for bilateral lateral edema, and we all know the three organs that are mostly connected to it, so heart, liver, and kidney. But with these three organs, we usually expect a fingerprint in the lab, so focus on albumin, liver function test, BNP. If we have a lab negative bilateral edema, the venous stasis, especially in a patient with increased intra-abdominal pressure, like in pregnancy, is one of the most common diagnoses to make, especially if there's a hematogenous or a hypercoagulable disease in the background. Then we learned that we have an inflammatory state, but it's radiographic negative. So Rabih taught us we should really investigate where is the infection or the inflammation hiding. So we concentrated on blood-based diseases that could be either due to like a cytokine storm or like generally blood-based diseases. Because then we kind of distinguish between macroscopic and microscopic blood-based diseases. There, the culture can help us. If the culture is positive, we expect macroscopic. If it's negative, we should also perform a PCR, a smear, and do earn blood cultures and focus on epidemiology, because microscopic diseases can hide in either RBCs, monocytes, or neutrophils. The lab really reveals pancytopenia, so we focus on a hectic hematogenous syndrome in our patient. The most common causes for that we learned are sepsis, liquid cancer, tick-borne disease, or lupus. We didn't find a fingerprint in our patient, and in the whole picture with elevated ferritin levels, AST, fevers, the CXCL9 make us think of HLH. Still, we have to keep in mind that HLH is not a diagnosis itself, but rather like a symptom of the body reacting more than we expected. So we should hunt for secondary causes of HLH. Lastly, we learned, or not lastly, but we also learned that if we have a suspicion for parvovirus, the PCR is definitely more sensitive than the serology. Rabih also taught us an interesting fact, which I didn't know, is that the sickle cell disease can also trigger HLH itself due to like bone marrow necrosis or fat emboli. But lastly, my favorite teaching point for today is that we should keep the fetal in mind, and it can also be used for, or can be used as another vital sign in OBG. So that is the wisdom we learned from Greg today, and I've learned a lot. There's a lot to read, and Sawsan and Rabih, thanks for the wonderful discussion.
Julia, I love how hard it is for you to say lastly, because you just the teaching did not end. Greg, this was a really, really special treat. I think you're getting multiple requests from the chat to keep the learning coming, and we hope to see you back as a case presenter, but probably as much more, we hope.
Absolutely.
Sawsan, is a real treat. You did awesome. Thank you both so much. And a big shout out to our scribing team. I saw Ethan was helping out, but Johan, he took it with a really, really complicated long case. So thank you both so much. Bye, guys.
Thank you.